All right, so I want to welcome and thank everybody for attending our Tuesday talk session. And before we begin, I just wanted to introduce our CEO, Gretchen Manning.
Thank you, Joe, and welcome everyone. As I was saying, it was so nice to see Lisa face to face again after all these years, and it's such a wonderful way to meet you directly, Dr. Shih. So thank you both for joining us, as well as our full team, or most of our team here from Ronald McDonald House Charities in New England. And I welcome all of our participants from around the country and possibly around the globe who are going to learn about proton radiation therapy. Mass General was one of our very first partners for our Ronald McDonald House here in New England, especially our Boston house. And has one of the one of the very first.
And everyone
Maybe I
would
could
want
ask
somebody to answer me a question I can't answer.
Joe, do
Why
you
are
want
we
to
the tag?
manually kind of
What's about the
perfect. Thank you. Just if folks could mute themselves while if they're not talking. But I was sharing in it, it's an important point that Mass General was one of the very first, if not the very first, proton radiation therapy programs in the country. So we are very fortunate to have them as our partners and excited to hear more today. And the more we know, the better informed we can be for working with families who are undergoing proton radiation therapy. So with that, welcome everyone, and I'll turn it back over to you, Joe.
Sure, that was an awesome introduction. I've had the pleasure of working directly with Lisa, just coordinating the families that we serve here at the Ronald McDonald House in Boston. Lisa is the Senior Proton Access Manager in Radiation Oncology. And then we have Dr. Shih. It's a pleasure to meet you as well, Medical Director at the MGH Proton Center. And with all that being said, I'll turn it over to the two of you.
Great. Thank you so much for having us. I think we're going to start where I'll go over a little bit more of the formal part of the presentation, and then really just so that we're meeting, optimizing in terms of the needs or the questions that the audience may have. Just really want to open up the questions to help better guide us, and probably have Lisa lead that part. So sorry if you're hearing this background noise. Okay, so I'm proton therapy, radiation therapy at Mass General Hospital again. Yes, I am one of the radiation oncologists here. In addition to being the medical director of the proton program, my area of clinical expertise is in taking care of central nervous systems, is mostly brain and spine tumors as well as ocular tumors. So for the agenda, what we want to go over is first just to review again what exactly is proton therapy. There's definitely a clear benefit or interest in for pediatrics particularly. Why so? And then a little bit of the history of protons at Mass General, which I think is always sort of interesting to understand that it's actually not that long ago, all these recent advancements, and they're right here in Boston. Where we are with our proton program today, and then a little bit more focused down to our practice as pediatrics and additional resources. So here's a little bit of the physics part of it, which is this is a depth dose curve. The y-axis is the radiation dose, the x-axis is depth, meaning like depth into a person or into tissue. Ideally, what we want to do is give the radiation just at a certain depth where the tumor is, and that's it. We don't want anything being exposed for or after a tumor target. The reality is it's not quite that good. So protons is pretty good. What we do is we have a radiation beam that comes in from the left. It hits that y-axis, which is like skin, enters a person. There is actually always radiation dose delivered. So it's not nothing, it's not perfect, but it does have this peak right where you want it the highest, and then the beam drops off very quickly. In comparison, what we get with most other radiation, which are all photon techniques, what you get out of a linear accelerator and other kinds of machines like that, is that the radiation dose peaks very quickly. So it's just a little bit underneath the skin or in the skull of a patient if we're treating the brain, and peaks there, and then it just peters out. And then that radiation beam goes out the other side of the person, such that if you put a piece of x-ray film there, that's how you get an x-ray picture, like a dental x-ray or chest x-ray. It's showing you the difference of what your body did not absorb in terms of that radiation. So neither of these are ideal, because the ideal again is the blue, but the protons is a little bit closer there because there's less radiation dose upstream between the skin and your target for a given beam, and we eliminate virtually all the dose downstream, which you see here. Tissue at its death receives almost no radiation. And then some of the key characteristics of the physics of this proton beam is this peak, which we call the Bragg peak. Again, the proton beam has a limited distance that it travels into tissue, and we can control that. Higher the energy, the deeper it goes. A little lower the energy, we can bring it more shallow. We can spread out this peak too to make it as wide as the target is. And hopefully by doing so, we reduce the amount of excess radiation exposure to a person where it's not needed, and less radiation means hopefully less side effects. So just to summarize again, the proton beam is a beam of radiation that travels a set distance and gives off most of its radiation at its end of its beam path. This is that Bragg peak. Whereas photons, also interchangeably called photons, X-rays, we use much higher energies than we do for diagnostic X-rays, and then you can see it travels through and through. So this is a cartoon, just kind of get that sense of and a lot of my examples are going to be brain related, forgive me, because that's my disease site area. But you can imagine a beam coming in, it's treating this target with X-rays. You have to accept that there's going to be a little bit more radiation dose upstream and downstream. And we try to spread that out to make it so that's not that intense, and the highest dose is in the target. With protons, you don't need to spread it out. The highest dose is already in the target. Because the beam ends, there's much less radiation exposure elsewhere. How does that look when you actually put it on a person? This is not that either, but it's one more step closer. It's CAT scan. These are actually radiation planning images. This is a cross section of a person's head. This is air, the black sinus, frontal sinuses. The nose is up here. You can see the right ear here, the left ear here. The body comes out of the screen towards you. This is the brain stem, the optic chiasm, so vision, where the vision, the optic nerves intersect. And you can see this tumor target with protons. The beams come in from that side, treat the target, and there is a dose fall off, meaning there's this gradient radiation from high dose to low dose, but it's definitely much more contained than you get with photons, where you have this just a low dose going through. My X-ray picture example, right? So each one of these beams creates that opportunity, which we don't really want. In adults, actually, most adults can tolerate this low dose radiation pretty well, but in kids, even this low dose radiation blue is really detrimental in terms of neurocognitive development and growth. The history of protons at MGH began in 1961. This is the building, the Harvard Cyclotron Laboratory. It's in Cambridge on Harvard University campus. It was actually built as a physics laboratory to do research, but the physicists there were like, well, why don't we use this to treat people? I mean, the physics that I just reviewed seems to make more sense for people, and they reached out to Mass General physicians, and they began this program. This is, of course, all before the regulatory things that we have nowadays, but that time, patients literally went there. This is what it looked like inside. It's not, it looks more laboratory than perhaps like patient friendly facing. This was a photograph from the maintenance of the cyclotron, which is where protons actually get accelerated. And this facility treated patients for 40 years, closed in 2002 after treating over 9,000 patients, and many of these were pediatrics. And before it closed, though, the second facility, and this is now the first hospital-based facility at Mass General, called the Northeast Proton Therapy Center, opened in 2001. It took a number of years for construction because it was the first of its kind. And so it was quite a feat. But once it opened, then the other facility closed in 2002. This facility got renamed to what it's called now, the Francis H. Burr Proton Therapy Center. And this just shows you some of the schematics and the photograph of where that large machine behind the walls accelerating protons lives. This is the blueprint. So that cyclotron picture I showed you is back here. All this lavender is concrete. And the red here is the beam line. This is a vacuum tube where the radiation beam travels in. And all these little squares and rectangles are different kinds of magnets that focus, accelerate, and turn the radiation beam. So we have two main treatment rooms, gantry 1, gantry 2, and only one room will have the radiation beam on. So while we're treating a person in gantry 1, treatment room 1, we're setting up in gantry room 2 and treatment room 2. There's a control room associated with each of the treatment rooms. The radiation therapists spend a lot of their time, most of their time, helping the patient set up in the room, and then only step out to actually deliver the radiation treatment. And then we have this third room where we do specialty treatments. Used to be for the brain, this radiosurgery. which we are no longer using actually currently, just became antiquated. And then we're treat eye patients here as well, ocular tumor patients. This is a picture of what the actual treatment room looks like on the inside. It's very large. This platform that the patient lies on is similar to a surgical table. It has 6-degree of motion, so you can tip a person slightly to the left or right, or roll them up towards their head or toe. And these minor little adjustments are used just to make sure we're spot on for the actual radiation treatment. The radiation beam, proton beam, comes out of here, and this is called the gantry, and this rotates 360 degrees around the patient, just as this platform, which we call a table or a couch. We don't really know where these names come from. Doesn't look like a table or a couch, but that's what it's called. This goes in and out, swivels, and up and down. So between the gantry head moving and the couch and table movement, we can get to a patient just about any direction for radiation treatment. Behind the scenes, again, this is pictures, photos of the actual cyclotron open. It's not operating when it's open like this, but there's a lot of maintenance in terms of cleaning that goes on. And then there was our third facility, which is now open, the Gordon Brown Proton Therapy Center. This opened 3 years ago in 2020, just before the pandemic in February, right when that was happening. This is a custom made, also first of its kind at MGH. You can see it's actually, I don't know if you can tell, it's much smaller. It's like all kinds of electronics, cars, cell phones, computers, you name it. The first version is big, and we're so happy it works because it's the first of its kind. And then over years, you figure out how to make the technology better, smaller, more compact. And so we get that with protons also. This has an integrated miniature like a CT scanner. So we can do what we call cone beam CTs, get 3-dimensional images of the patient. It just scans down, up and down this table the patient lies on. And because of the movement of this table, we can turn so the patient's treated from either like the left or right side. So this gantry is much smaller. It doesn't rotate 360 degrees because we can move the patient to get to the other sides. So in summary, in terms of our 2 centers, there's the Francis H. Burrs Proton Therapy Center. The vendor is IBA. We were the first facility for IBA, which is now the largest proton vendor in the world. Is a 260 MeV cyclotron, which you saw, the 2 gantry rooms like you see here. And one of there's that fixed beam room. Fixed beam meaning the beam doesn't rotate, so the patient comes to the beam rather than the gantry moving around the patient. We can treat up to 30 to 40 patients per day between the 2 main treatment rooms, and then additional few patients who have eye tumors. Many of our patients are from out of town, which why we're very dependent on a Ronald McDonald House in a very symbiotic, wonderful way so that we can offer best care for these patients. And then the second facility, the Gordon Brown Proton Center, I showed you, this is schematic, early schematic, and the actual photo of the machine opened much more recently. The vendor here is Proton International. It's a single room. Actually, the accelerator is different. It's called a synchrotron. It works a little bit differently, but still produces high energy protons. It doesn't have a 360-degree gantry, the part that moves, but it's 190 degrees, just a little bit more than halfway, because that's all we need to get all the different configurations to treating a person. And what's nice about it has this 3-dimensional imaging, again, the cone beam CT, in addition to the more traditional 2-dimensional, just sort of X-ray pictures that we can take. Accelerating protons, high energy. This may or may not be meaningful depending on your physics-ish type background. Some people find it really fascinating just to hear that it's, again, 230 mega electron volt. The accelerators that we use are either synchrotrons or cyclotrons. We have one of each now, since it's a cyclotron Burr, a synchrotron that's used in Gordon Brown. These are just additional photos at Burr. You can see a patient being treated set up from the side, and here's a patient that's being treated for the eye tumor. The nice thing about the eye tumors is that we go through the white of the eye, which is pretty resistant to the radiation. It treats the tumor in the eye, and then it stops. So the brain itself receives no radiation, which is quite nice. And this is Halloween. Our therapists are very much looking for opportunities for fun themes, just as butterflies here, and set up for a patient. The color schemes are, designed to whatever the patients want. They play the music that patients want. I actually don't have a photo in here, but up in the ceiling here for kids, we actually can play movies also. We just kind of mark where they are so that to be continued when they come in the next day. So there's certainly a lot of active creative efforts to make the experience as positive as possible for kids. And here again, the Gordon Brown facility, patient being set up for treatment there. And you can see where he's rotated the other way so we can get from the left side and the right side. meet some of our experts. We are super specialized, so clinicians really find their niche. I've already heard a little bit about me and the brain. Some of my other colleagues, Dr. Ted Hong, he directs both the gastrointestinal services, but also oversees our research program. Dr. Tornyak is one of the most important people you'll need to know. She is led our pediatric service for over 2 decades at this point, treats anything pediatrics, but also has a practice where she is able to treat everything in adults as well, but pediatrics is certainly her main focus. Dr. Rachel Jimenez is a breast cancer specialist who also leads our randomized breast protons versus photons research trial, and also is the head of our quality assurance program at Mass General. Dr. Shannon McDonald is our other primary pediatric radiation oncologist. Her primary practice now has kind of shifted a little bit to adults with sarcomas, but they're very similar to what we see in kids a lot too. So there's a lot of analogous strategies in terms of the treatment, but she also has a wide range of pediatric experience in everything. And then a very other common use of protons in mostly adults is with head and neck cancers. Can manage treating things in your throat, between your eyes, and so forth. Minimizing the radiation to other parts of the things in the head is critical just to reducing short and long-term side effects. And Dr. Annie Chan is our service director there. In terms of the care team, it's pretty complex. You know, yes, there's us as the radiation oncologists, it's the docs, the other main docs, multidisciplinary care in terms of pediatric, medical oncology, surgical oncology. We rely heavily on our nurses and nurse practitioners or other advanced practice providers, physician assistants also. Lisa, as you heard, is our Proton Access Manager. That's where it all starts. Our radiation therapists are very engaged into the day-to-day connecting with patients, kids, and parents and families, and also there are eyes and ears. They'll alert us when like something seems a little off. You know, we need to take a look at this, and so that's great. Social services, nutrition, dietitian, and as well as a child life specialist. Again, this is a little bit more on pediatrics, specialized. We treat more than half our patients are still adults, just because most of cancer is adults. But there's definitely a huge emphasis on pediatrics because the needs are a little bit different for kids in terms of like side effects that are specific to things like growth and development or prevention of those side effects, and also supporting the needs, not just physical, but I think there's a lot of emotional and mental health concerns also for teens, young adults, and also extended family. What are some of the fun things that we try to do with them? As you can see here, the mass, we like to, kids can be as involved as they want, or we can just create it for them. They can be their superhero of interest, and that has been quite popular. Other things, some of these things I've already mentioned in terms of child life specialists. We have peer mentoring programs. The younger kids, oftentimes, I have the next slide on anesthesia. Some of the older kids really benefit from just kind of connecting. I was there, I did that too, I got through it. This is what it was like for me. And just knowing that like if someone else like me was able to get through this, I can too. And then there's themes. So you saw Halloween. We also do in the holidays, the Polar Express Day. Everyone dresses up. There is a weekly toy Fridays. There's a toy to pick. It's like going to the dentist. It reminds me of going to the dentist. Every Friday, you make it through 5 treatments. You can pick a toy. We also have toys for siblings as well. We do treat just about all of our pediatric patients with protons. Some of the common ones are listed here, but they tend to affect things like the brain, the soft tissues, muscles, bone, and eye tumors as well. I had mentioned anesthesia briefly. How do you know when a kid needs anesthesia? It's a really personalized decision that is based on the child's age and development. So I would say on average, age 7-ish and younger are ones that we more strongly consider as potentially needing anesthesia. But it really just depends on how they are. Like they've been through scans, CAT scans, MRI scans before they've gotten to us. How do they do with that? How long will the treatment be? Are they going to be in the machine for an hour versus 20 or 30 minutes? What are the other technical devices that we need? Like how much can we afford? Like what's the risk of them moving? And what is the family would like to? Sometimes families are more reassured, just thinking, you know what, I just feel more reassured that they're under anesthesia, or sometimes it's the reverse. Let's see if we can coach my child who's sort of that age cusp to see if they can actually maybe avoid it, which is more common. We do, because the patients are not able to eat within several hours before treatment, we do try to let the fasting be overnight and try to treat the kids first thing in the morning, give them preference in terms of treatment slots. We work with our nutritionists to make sure this is safe and to provide some minimal or additional nutritional recommendations as needed. Central lines are placed in all patients prior to first day of treatment. So for ease and safety of being able to deliver anesthesia and any other additional fluids for recovery. And patients are always seen in a multidisciplinary sense. So it's not just a radiation oncologist, but they also have a pediatric medical oncologist as well. There are additional integrative supportive therapies as alluded to, and this is both for patients as well, meaning not just the kids, but also adults and their families, and a variety of them are listed here. Most of these are funded through philanthropy or supporting organizations within the hospital, so they're complementary for our patients. And some of these are adults only, acupuncture and massage mostly, but you can see some of these other ones are more for kids as well. And this is my last important slide. It's like, how do you connect to us? We've already heard about it. Lisa, hope you don't mind. She didn't know the slides coming. I made a big picture of her. It's like, she's the point person. Like, all traffic flows through her. She has the best overview of like, what do we have available? Who do we need for this? She's seen every permutation for adults, kids, and in between. This is her number. Best way to reach us is information, radonc@partners.org. And with that, I thank you for your time. This is the team. Happy to take any questions.
Yeah, that was great. Thank you so much. Very informative. And I really loved hearing about all the supportive services you guys provide too. That's really excellent to hear. Yeah. I guess one question that was kind of sticking out to me is this sort of radiation therapy making other therapies more obsolete, or do you feel like this is more specialized and those other therapies that might have more side effects are always going to be necessary too?
That's a really good and tough question. I feel like one day it would be nice not to have any radiation therapy. I mean, the sobering truth is like, in as much as we try to really champion and make it as positive experience for kids to get them through, and the families are just so relieved that like most of the time, more often than not, we are successful at curing. We never really say cure because we don't know until we're there, right? But controlling whatever disease is at hand with the multidisciplinary chemo, radiation, surgery, the reality is like there are huge risks. I didn't really go into this, but like of side effects, late side effects of radiation treatment. For example, of the brain, we always worry about things like neurocognition. In the first year or two, my kid seems normal. My kid's going to the next grade, okay, but maybe not in 10 or 20 years. And you realize, so they're just a little bit behind or lagging in our class. Is that because of radiation or is that because of them? Those are like, and we've learned a lot just from prior experiences. So now we've pushed to minimizing any use of radiation as much as possible in kids. And when we do use it, can we use a lower dose? Can we use a lower area so we don't have to treat the entire brain, for example, or an entire section of a body? I think the late side effects of radiation they're just sobering and real. And I think they're always there. I actually just saw an individual yesterday. He was treated kind of like in his late teens, but it's like 30 years later and he's got a radiation-induced tumor in the brain. So, he got cured from one thing, just to have to deal with this harsh reality 30 years later. So those are things we say, well, yeah, the lifetime risk is really small, but like how small? I mean, it's not zero or not, it's not perfect. So, I mean, it's a little bit of a long-winded answer to what you're saying, but like, I think protons is better than regular radiation in many circumstances because it reduces the risk of side effects, both now, but perhaps more importantly in the future, just by reducing the amount of exposure radiation. But one day, the perfect treatment actually is probably no radiation.
I found this to be fascinating and I learned so much. So I thank you for coming on and sharing your knowledge and just even seeing, having the visual of it. One of the questions that I had is, and you touched upon it a little bit, but the time that the patient or the child is in the radiation, receiving the treatment, that can vary based on their diagnoses. Yeah. And is there a general range? Is it not over, X amount. That's something that sometimes the grandparents will let you know. The parents seem to be very dialed in and, educated by all of you. And then the support structure around them, whether it's a grandparent or not, or an uncle, kind of it will sometimes ask those questions too.
So I can answer that, but Lisa actually is in charge of the schedule. So maybe you're even more precise. I'll let you take over.
Sure. Yeah. So it really can vary depending again on that disease site that we're treating. Also, the other factors that Helen touched upon, are we choosing to use anesthesia or not? Of course, understandably, that would add a little bit more time to the treatment room. On average, I would say 20 to 30 minutes for a general pediatric patient. That's a fairly straightforward case. Even with anesthesia, if it's like a simple case, like a brain case, we could do within 30 minutes. At the end of the day, we always try to just make sure we minimize the amount of time in the room, regardless of what treatment site we're doing. But if it's an anesthesia case or if it's a more complicated case, some of them can be in the room for up to an hour, but that's really more also including bringing the patient in and getting them onto the treatment table, all of the team members doing what they need to do to set the patient up, verify where they're treating, and deliver the treatment itself. So it's not that they're in the room getting treatment for a full hour, which I find that when you explain that part to some families, it helps ease that mental stressor of hearing they're going to be in there for 30 minutes or 60 minutes. And you realize, well, they're not alone, right? They're not in there for just that time by themselves. They're actively seeing the same 4 to 5 faces every day, and quite often get to know their teams really, really well. It becomes kind of an experience for them with their team, and they get very close with them.
Yeah, and I think another important point that I didn't make is that you don't feel radiation. So it doesn't hurt, it doesn't sting, it doesn't burn. Most people can't tell when the beam is on or off. And it's usually on for about a total of a minute, 2 minutes tops per day for a section. Like if you're treating a large area, then it could be you're treating in chunks. But if you're just treating one area, it's of that 20, 30 minute in a room, only about 1 to 2 minutes actually exposure to radiation.
It's like having an X-ray. That's what we tell patients to expect. At the most, you'll hear some buzzing. You might hear the machine moving around you, but some patients even fall asleep when they're in there. Or they just choose for the young kiddos that are able to do it without anesthesia, that really great benefit of having the monitor in the ceiling. They're able to watch, shows or movies of their choice. Some people listen to like music and whatever they choose to in the room to pass the time. Are there any other questions?
I guess
Go ahead, Joe.
I was going to ask if is it typical that like proton treatment would be the first step in treatment, or is it the case that some of the kids that have stayed with us have been through treatment prior and then they come for proton treatment? Is there a typical trajectory for that?
So for a pediatric strictly, a lot of the cases that come to us are typically coming either post-operatively or after a few cycles of chemotherapy. Again, this could be very diagnosis specific, but yeah, usually we thankfully have a little bit of a heads up from referring facilities about when the timing is for that treatment. And Joe, I'm sure you've kind of dealt with us saying we think we're starting on this date and that date might change. And that can happen if a patient is coming after, say, 3 cycles of chemo, but between cycles 2 and 3, the third one gets delayed. So that's where myself and a lot of the other coordinators and physicians in our department come in, constantly checking to make sure these patients are on track with the dates that we're booking. This, I don't think we've touched upon it, but like the average course of a radiation treatment, again, for this crowd more specifically with pediatric, is anywhere from like 28 to 30 treatments altogether. It's Monday through Friday, 5 days a week. And we see them every day until they're done. Occasionally, if there's like a holiday in there, we usually will close for that day. But since it's a rather large commitment of time coming in to see us, we really do rely on you guys to help us out with finding a home away from home, so to speak, while they're here for treatment. But even more important for us to verify that the timing of their radiation start is on track from when we book it.
A great partnership for sure. and we may already do this, but this is me having a little knowledge sometimes is dangerous. But if we don't, it might be something interesting to look at, especially because our Proton family stay with us for such a length of time. But if you are having kind of theme days with the kiddos, it might be something that we could look at on our end of having that kind
Oh,
of
that's great.
joint theme day. So, it's familiar to them, and it's kind of a day-long celebration or something might be
Great idea.
fun
Sure.
that we could consider,
I love that idea. They're fairly predictable, like Polar Express Day, something we do every year around like the Christmas kind of winter holidays, but we can always let you know exactly when that is. Halloween, we always do, the costumes and whatnot, but there's other days like opening day for Red Sox or Patriots. And we just, any occasion to celebrate and make it more fun to come in, we try, and the therapists and the other staff in the department always participate. So maybe I can put together like a tentative schedule and send it along to Joe for you guys to have.
that would be awesome. No extra work on your end because you already have more than enough to do. But if there's something low hanging that you can always send us, it'd be awesome.
No, that's worth adding to the list for sure. Any other questions about just kind of what patients kind of expect or see when they come in, or even just families, like any questions you guys get from families that you think might be helpful for us to know about?
No, I hear it's been really nice, when we've had multiple families who are all going to MGH and receiving proton treatment. Just the connections that they're able to make with each other is really awesome. And it sounds like you guys really help facilitate a lot too on your end. And I've heard a lot of great stories, even families that aren't staying with us. A family here, might be a family at the center, and they just make really awesome connections. So it's great.
Yeah, we do. Thank you for telling us. We do love those stories too. A lot of these families will almost schedule their like annual follow-ups around the same week. So they'll like take the two families will vacation to Boston for like 3 or 4 days, and it's really fun. And that's both domestic and international. Sometimes we'll have families like all from, Canada or wherever. If they happen to be here at the same time, they'll try to come at the same time again, we'll do our best to do that too, because it's a lovely little thing to look forward to.
Any other questions from anyone? No? All right, well, thank you guys for doing this talk with us. It's awesome. It's a great relationship that we have, and I'm super privileged to have you here today to explain a little bit more about proton therapy with us. And for everyone else on the call too, I just want to remind you that we have another session coming up on July 18th at 1 p.m. It is with Boston Children's Hospital's Creative Arts Program. So feel free to reach out to me if you haven't yet already to RSVP for that.
Great. Thank you so much for having us.
Thank you.
Thank you.
Thank you, Lisa and Dr. Shih and Dr. Yak and Dr. Weinstein and everyone at MGH for just being phenomenal partners and the superheroes that you are to the kiddos we jointly serve. So this has been very informative. We appreciate your time.
It's very much a
Likewise.
team effort. Thank you.
Thank you.
Take care, everyone.
Bye-bye.
Bye.